case that I discussed at Morning Report. And I said, we really need Dr. Tolwani to discuss it, so we have somebody competent to discuss it.
Yeah, I wish all AKIs were so easy to determine the cause. Just kidding.
Kiara, unmute yourself and say hello.
Oh, hi, Uncle Bob. I'm very happy to be here, but I'm very nervous.
Well, tell us something about you.
Well, I'm from Peru, from Lima, Peru. And well, today I present a case for CPS Morning Report, a neuro case, and Dhruv was an amazing discussant. And yeah, I'm nervous because I'm not that good at nephrology, but I have willing to discuss since many time here, so I think today's the day.
Today's the day. And Dhruv, the man who needs no introduction.
Well, yeah, I guess. Hi everyone. I'm Dhruv. I'm an MS4 over at VCU School of Medicine, MCV for all the old timers. Applying med peds this year, and yes, UAB is on my list. And again, really excited to discuss today.
Okay, so the way this will go is we're going to let our two discussants go ahead and say what they think at each aliquot, and then Dr. Talwani. Oh, so introduce yourself, Ashita.
Oh, hi, my name is Ashita Tolwani. I'm a nephrologist here at UAB. My specialization is probably in ICU nephrology, and I really enjoy acute kidney injury. I was on the consult service today, and we had a lot of cases that were difficult to determine the etiology, so I'm looking forward to ending my day with something complicated too.
And just because you deserve to be positively embarrassed, the winner of this year's Nairns Award. And could you explain to them how cool that is?
It is very cool, and I'm very honored. That is it's a Lifetime Achievement Award that is given by American Society of Nephrology for someone who's made major contributions in education. And I was very, very, very honored to have it, overwhelmed. And there's a lot of great people before me, so I have big shoes to fill.
And we all know that you can fill them great. So Dasher, I feel like it's got to be Christmas because I'm calling on Dasher. I don't know.
Hey, it's too soon. It's too soon. Come on, you got to give me at least. Well, actually, no. The decorations have been out at CVS for at least 4 months, so I think you're okay.
Oh God.
Okay. So we have some numbers. Tell us a little bit about the story.
All righty. So I've got a patient. This is Mr. C. Mr. C is a 43-year-old male. He's got a past medical history of hypertension alone, coming to the ED with a 3-week history of severe diarrhea. And down in the ED is found to have a severe AKI.
Okay, Kiara.
Hi, so just for the chief complaint, this is a young man with hypertension. So first, when I think about hypertension, I'm wondering if this patient has controlled hypertension or not. And if every patient with cardiac issues and with severe diarrhea, I wonder if this patient could be hypotensive or have some volume depletion. And with that, when I see the labs, I can see now hyponatremia. So maybe this is consistent with his diarrhea, and maybe he has volume depletion right now. I'm not very familiar with this, but 6.3 is the potassium, right?
Correct.
So this potassium is, it's okay, yeah. And 104 is a chloride that is slightly elevated. 16, I believe. Thank you for putting this. The bicarb is very low right now. So maybe I will be thinking about metabolic acidosis. And with that, I would like to check the anion gap. And the anion gap would be 16.
It's 12.
20. Okay, so with probably an non-anion gap metabolic acidosis. And so far, I'm concerned about this AKI because he has a elevated creatinine. I don't know his baseline, but 7.7 is an elevated creatinine. So I wonder this is a pre-renal AKI. And with that, I will be treating him immediately with some volume.
So, Dhruv, what are your thoughts before we get Dr. Tolwani to talk about how she approaches something like this?
So the first thing that I'd basically ask is, has this because this guy's had severe diarrhea, has he had any fluid pushed into him? We don't want to make the determination of AKI without getting his volume without determining his volume status and determining whether or not he's had fluid pushed into him. Secondly, that potassium is high. For the benefit of Kiara, the normal potassium should be anywhere between 3.5 and like 4.5 to 5. So that potassium is actually super high. It's his hypertension past history is interesting. It's it was mentioned in the chat that there's possibly something related to his, like, he might have an overactive renin-angiotensin aldosterone system. I'd want to see what medications he's on. Like, is he supposed to be on a lisinopril or something and he's not taking it? Or is he on a spironolactone and that's maybe causing his potassium to be jacked through the roof, and his sodium is low. His anion gap is normal. Depends on whether or not he has enough albumin in him, given that he has severe diarrhea, and I don't know if he's maybe wasting or if he's consuming protein to the point where he's got low albumin in him. His BUN to creatinine ratio is, it's close-ish to 10. So it's probably an intrarenal and not a prerenal cause. So I'd be looking somewhere in the kidney at this point.
So here's the question. You only get to say one thing. What next test would you order? First Kiara, then Dhruv, and then we'll let Dr. Tulwani teach us how she looks at it, because she looks at a lot more of these than we ever will.
Sorry, me first?
Yes.
So I would like to order a urinary analysis.
You like a
Same.
urinalysis. Okay, good. Dhruv, what do you want?
To be more specific on the UA, I'd want urine lights.
Okay, so you don't want a regular urinalysis. You just want urine lights. You got to get pick one of the other, Dhruv.
Pick one or the other. Actually, no. You know what? A UA just to start with.
Okay.
I just want to see how hydrated he is.
Okay, Ashita, we have these great medical students who need your wisdom.
Sure. So one of the keys for determining the etiology of AKI, you guys hit it right on the nose. What's really more important than anything else is a clinical history and medications. And so absolutely, history is important. How long is it hypertension? What medications has he been on? Has he been on an ACE inhibitor? Someone asked that. Has he been on an ARB? Has he been on, diuretics? Has he been taking non-steroidals? Medications are key. And also history of diarrhea, dizziness, things to assess volume status. But if you were going to ask me the one test that I would like at this point too, there's a lot of tests I need, but I always like to start off with the urinalysis also. And basically I'm looking for all those things that you guys talked about is, is there proteinuria? Is there hematuria? What's the specific gravity? I personally will spin the urine myself to look at it to see if there's granular CAS, if there's a CAS consistent with a GN. I think that would be very easy to do and very fast to do, because you can get that faster, do it yourself before you can get other labs back that may suggest more of an etiology or diagnosis.
Ashita, they discussed the basic metabolic panel. How if all you present is this basic metabolic panel,
Interpret it.
how do you analyze that, and
Sure.
what tips can you give to everyone?
So unfortunately, having a basic metabolic panel like this with, creatinine that's elevated, there's absolutely no way to tell if this acute or chronic. Okay. And so, and there's no way to tell if this is pre-renal or intrinsic. As we all learn in medical school, your BN to creatinine ratio is greater than 20:1, but unfortunately in real life that doesn't apply. And so it's very difficult just with this metabolic panel for me to say that he is pre-renal or not. And that's where urinalysis and physical exam would be much important. Someone mentioned the potassium being out of proportion. Again, that can be dependent upon medications he's had. A lot of things I think about too is when I see potassium extremely high in this type of situation is if he has some sort of obstruction. He is 43 years old. He could have prostate issues too. And obstruction will definitely cause a low bicarbonate and a hyperkalemia. Some of you in your discussions have mentioned renal tubular acidosis as a cause. Honestly, anytime you have renal failure, you essentially have a tubular acidosis because you can't generate, you can't secrete hydrogen protons. And so essentially you can't cause anything in this situation with this severity of renal failure as an acute kidney injury, as an RTA. The other thing, when you look at this in terms of analysis of the acid base status, it's very hard for me to make a judgment again until I have an albumin also to be able to assess whether this is truly an anion gap or non-anion gap acidosis.
And everybody learns this in a different way. I know the way that I teach it, but once you have the albumin, how do you use that? Because I think that's really important to think about in a patient like this.
So basically, albumin, a low albumin will lower your anion gap. So there's a correction factor. There's many that you can use in Google and use Med Calculator to correct for the albumin or the anion gap for the albumin. For instance, this patient's anion gap is 12. However, if the patient has an albumin of 1.2, maybe he has a nephrotic syndrome, we don't know, we haven't seen the urinalysis yet, then a corrected albumin would be in the range of somebody having a metabolic acidosis.
So knowing the albumin, for the sake of stretching this out a little bit, the urinalysis, let's wait. But most of us at UAB use albumin ×3. I know that's a rough estimate. Is that good enough for you?
Yes, that's a great estimate.
Okay, so do we have an albumin?
It is 3.2.
Okay.
So that means that we'd expect an anion gap of around 10. It's 12. We can't get too excited.
Not at all.
Okay. They wanted to know the meds, and I think that's worthwhile before we finally get to this urinalysis.
So his current medications include absolutely nothing.
Wait, what? And he's had hypertension for how long?
Great question. Am I allowed to answer that?
Yes.
So about 5 years, he thinks. He doesn't really like to go to the doctor very much.
So that's interesting. And they wanted to know whether there was any baseline labs on this gentleman.
No, we have no baseline labs.
And actually, the best way to tell if someone has underlying chronic kidney disease is going to be a baseline lab, by the way.
How convenient that we don't have one.
I figured sounds like, I've seen this patient.
Yep.
We happen to know that you didn't see the patient, but your colleagues did.
Yeah, I've seen similar patients. So.
Don't ruin this for me.
So anything else in the review of systems that might help us in any way?
Yeah, so as far as extra review of system stuff, really the biggest thing is he's been having just a lot of diarrhea that he describes as kind of like loose, liquidy, and clear and jelly-like. Otherwise, review of systems just reports a kind of decreased appetite, but otherwise, that's really about it. No nausea, no vomiting, nothing that you would really, be normally concerned about.
He felt totally normal 3 weeks ago.
He did.
Weird history question, but has he been drinking like lake water or any sort of weird water source at all?
Great question. So I don't believe that he's been drinking it, but he does currently have a job as a dock builder. So he works in a lake and builds docks, and he spends 4 to 6 hours submerged in the water every day.
Huh. Interesting.
Why'd you ask that question, Dhruv?
As soon as I heard the description of the diarrhea as loose, liquid, and jelly-like, I don't know why, but my brain just went immediately to Giardia, and I was thinking, did he get into a water source that had it?
So, Ashita, could an acute kidney injury cause the diarrhea, and could diarrhea cause an acute kidney injury?
So basically, acute kidney injury per se is not typically associated with causing diarrhea, but if you have diarrhea that's prolonged for a long time, then potentially you could have acute tubular necrosis. But there are also other renal etiologies associated with diarrhea that are more systemic, and I think that further labs may outline that, and that's all I'm going to say.
And I guess the other thing too, and this was mentioned in the chat, is that you can get glomerulonephritis from inflammatory bowel disease, so something like Crohn's or ulcerative colitis. So it's 43, a little bit young to get a colonoscopy right about now, and probably on the older end if he did have a first presentation of a Crohn's flare or a UC flare. So I don't know. I'd probably want to get an abdominal exam on him, and I also want to see that UA and see what it looks like.
I guess the other question before we leave the BMP, when do you get a VBG and when do you get an ABG?
I mean, for this guy, we'd probably get a VBG and it would be good enough. The only reason for me that I'd get an ABG is if I wanted to calculate an AA gradient, and VBG is just far easier to get, quite frankly.
So that would, the reason to get that is, could this possibly be a compensation for respiratory alkalosis?
Respiratory alkalosis, yeah.
And certainly if he had diarrhea, that he could have associated hyperventilation. By any chance, do we have an ABG or a VBG, John?
No, sir, I don't believe we do.
Okay, so
no, that's incorrect. A VBG, we have a pH of 7.2, and 47 and 18 are VBG results.
Okay, so Ashita, you take care of a lot of people with acid-base disorders. How do you interpret VBGs, and are you using those more than you did when you were a resident?
In terms of more than having arterial?
Yes.
Yes, I am. Yes, I am, because it's, unless you have some sort of misfast or shunting, they're very reliable still in terms of determining your acid-base status. I mean, essentially, I'm looking at more to see if there's compensation, et cetera. And essentially, I just used it today on someone else's to determine their metabolic, if they have a compensation respiratory component. So yes. Okay, so
Kiara, just to make sure that you understand the numbers in the U.S. So the pH should be the same everywhere, right?
Yeah, pH and bicarb. Yeah, I understand.
Okay, so how would you interpret those numbers?
So right now, he has a low pH with a low bicarb, so I can understand that this could be a metabolic acidosis. And with 47 CO2, I would like to do there's the winter formula to see if there is a compensated metabolic acidosis. So with that, I believe it's 18 plus 9. It's 27 plus 8. uh, 27, I believe 35, 36.
Mhm.
So I believe it is not a compensated metabolic acidosis right now, but is on its way to be compensated. I don't know if I'm wrong.
So you're going about this exactly right. So this actually is both a metabolic acidosis and a respiratory acidosis.
Yeah. So maybe I can add something that I would like to pass, because with these 3 weeks of diarrhea, this is chronic diarrhea, and in a young patient with chronic diarrhea, I'm always thinking about an HIV status. So I will also would like to know his HIV status.
That's a great question. Somebody in the chat asked, you did a wonderful job of using the winner's formula, Kiara. Sean, could you type it in so that I think it was Casey was asking about it, and the idea of the winner's formula, which comes from an article in the 1960s from the Annals of Internal Medicine. It's the way to predict what the PCO2 should be within 2. And in this case, as Kiara demonstrated so beautifully, we would expect to have a PCO2 of around 35 because she did the calculation very well in her head, which is really hard to do. And yet it's much higher. Now, you almost didn't have to do this because a PCO2 of 47 would be a respiratory acidosis. If there was a metabolic alkalosis, that could be compensation, but that could not be compensation for a metabolic acidosis. So you could have bypassed the winner's formula.
Mhm.
So that's sort of an interesting complication, is that we also have respiratory acidosis. Dhruv, why do people get respiratory acidosis?
So they're either not able to breathe effectively. So something like a COPD might cause it. I think the one thing that I'd probably ask this patient is, does he smoke? Has he smoked? How long has he smoked? How many packs a day has he smoked? And especially considering that he's a dock builder, he might have exposure. He might have like a restrictive lung disease that could also cause issues with his breathing. The other thing would probably be like just neuromuscular causes, but common things being common, I'd go after the tobacco angle first.
And what about medications? Let's say he was self-medicating.
Oh, opioids would be the other one.
So he might have taken opioids to try to slow down his diarrhea if he could get his hands on it. So those are worthwhile.
Well, Imodium would basically be that. So.
Yeah. So, Ashita, any comments about that?
I agree. I mean, the thought process for me is anything that causes a hypoventilation syndrome. And so essentially that would be any sort of neuromuscular defects. Basically, drugs do come in mind. He's 45 years old, and the population I see, you have to think about things like drugs mixed with cocaine that can cause worsening kidney function, hypertension, etc. Other things is, does he have any sort of neurological injury? We don't know anything about, no one said anything about his physical exam at this point, how alert he is, what his mental status is. And so those are the things going on in my head right now for the respiratory acidosis. Does he have a superimposed pneumonia? Does he have a fever? What does his chest x-ray look like? So as a nephrologist, I had to say we like lots of information.
So the great Dasher.
Yes, sir.
So why don't you go ahead and give us a physical exam? He said he wasn't taking any meds. Was he taking anything over the counter or anything that is not considered legal in this country?
So he was taking the occasional Goody Powder over the counter, which is everybody's favorite medication that patients love to just pour into random food items. Yeah, so he's taking some Goody Powders here and there. He is currently intermittently using cannabis, as he says. He smokes 1 to 2 packs of cigarettes a day and drinks 1 to 2 glasses of moonshine every now and then. So interpret that as you will.
Excellent.
2
Excellent.
glasses of moonshine. How big is the glass, and is that moonshine that he makes on his own, or is it, you know, the commercial, all that?
Great question. So
the wimpy moonshine.
he gets it from a friend who makes it, and I can probably tell you it's definitely not a glass like this kind of glass that I have, which is minuscule. It's a man-sized glass.
Alabama man-sized Dhruv.
Yeah. So just gargantuan, assumably.
So, Dhruv, what do you worry about with moonshine and kidney disease?
So I'm worried about, goodness. So I'd be worried about oxalate and the accumulation of oxalate, and basically just oxalate destroying kidney tubules. That'd be the big one.
Okay, so
I don't know if methanol can.
Because he was once my resident. Why'd you say urate? No, you said oxalate. Somebody else in the chat said urate. So where does the oxalate come from?
So oxalate would basically be from when you're distilling moonshine. Some of the basically it would be in the tail. So like ethylene glycol will basically get broken down in the liver into oxalate. I'd be concerned if he was drinking something like antifreeze or something. Then I'd be saying.
Okay, so you don't know what I'm thinking, Dhruv. So I'm playing games here. Because I saw the first case that I saw this was actually at MCV. That I don't know what this VCU thing is, but it was the same place.
Mm-hmm.
But the first great report was actually from UAB, and I have diagnosed Saturnine nephropathy at the VA within the last 3 years.
Oh, Saturnine, yeah, okay.
So what the heck is Saturnine nephropathy? So anytime you see moonshine, you have to think about lead intoxication.
Exactly.
Oh, because the vessels will basically
they often run these radiators that are lead lined. But this does not fit that syndrome.
Mm-hmm.
Now you really have, this is really nerdy to know about Saturnine nephropathy, but it's an interstitial nephropathy associated with gout, which is called Saturnine gout.
Mm-hmm.
And they usually have, I think it's an interstitial disease, and they usually have creatinines in the 2 to 3 range. Did I get that right, Ashita?
You're right. It's a chronic interstitial nephritis that's progressive over many, many years. So absolutely.
Yeah. So
and the diagnosis actually is not that easy to make. So
no.
So
it helps to take a good history and find out that they're moonshine. Okay, why don't we get to the physical exam, John?
All right, so the physical exam, he's a generally healthy appearing middle-aged guy, no acute distress, he's alert and oriented, converses with no difficulty.
He's not even close to middle-aged, John.
I'm sorry, I forgot that that term is now political. He's a young, strapping lad, no acute distress. His oropharynx looks great. He does have signs of long-standing sun exposure on his chest, shoulders, and upper back. His cardiopulmonary exam is completely normal, regular rate and rhythm, no murmurs, nothing like that. His abdomen was non-tender to palpation. He had no organomegaly, but he did have hyperactive bowel sounds. I'm glad that none of you are surgeons are going to roast me for being like, oh, it's hyperactive in 3 quadrants out of 4. I'm still traumatized from being a student and having them roast me for that, if you can't tell, but it's fine. Other than that, no lower extremity edema, no joint swelling. He's got a dry, scaly rash on his left hand. Other than that, no petechia, no purpura. All the rest of the exam, totally normal.
Except you didn't give us his vital signs.
I'm so sorry. I withheld the most juicy bit. So he is afebrile. His heart rate is 70. Respiratory rate is 22. His blood pressure is 161/93. He's saturating 95%, and his pain score is 0.
Not terrible. I mean, at least it wasn't like last week where the blood pressure was like in the 200s. Signs of significant sun exposure, hyperactive bowel sounds, dry scaly rash on his left hand. I think the hyperactive bowel sounds is probably going to lead us indicative of his bowels basically being so active that he's probably got diarrhea. Again, I still want that HIV.
You'll get it.
Just trying to think of what else we can sort of.
Will a CBC help you?
It might, if only to confirm what we're working with here. Is this an infectious diarrhea or is this an inflammatory diarrhea?
How else might it help you? It's not perfect, but it might help you. So let's say the hemoglobin is normal. Let's say the hemoglobin is 10. Does that help you start to sort things out at all? So Dr. Tolwani, you see people like this all the time.
Right. Are his
question?
kidneys still producing EPO? That's the big one. And if they are, he shouldn't be anemic unless he has like an iron deficiency or something. But if he is anemic and it's like a normocytic anemia, then you might consider that his kidneys are injured and that they're not producing enough EPO.
How good is that, Ashita?
It's a reasonable assessment, but I can't say that always your hemoglobin is going to predict the chronicity of what's been happening, unfortunately. For me, other things I think about in this gentleman, yes, his blood pressure is high, but I always worry about if he's still orthostatic. It didn't sound like from his exam that he has dry mucous membranes, et cetera, but you can see concentrated albumin, concentrated hemoglobin in this situation too. What I would be more interested, honestly, is also his platelets.
So we might as well go ahead and get the CBC because that's what we usually do first. Because we're trying to collect the urine to get a urinalysis, but the urinalysis never gets back that fast.
Yeah, they keep pouring in the toilet. I don't know what's happening. It's clearly ordered to please clean catch, but it's just not happening.
And there was a calcium on the electrolyte panel that you didn't tell us about.
Oh, I apologize. A calcium of 9.4.
Okay.
We got a white count of 12.5, a hemoglobin of 11.9, a hematocrit of 36, and platelets of 436.
Does that help you at all, Kiara? And if it doesn't, that's fine, because I bet Dr. Tulwani can tell you how it does help her.
So, yes, the hemoglobin, I believe it's okay. It's 11 point something.
I think it was 11.9.
So for a man, it could be like in a lower limits, but it's not quite, I'm not quite concerned about it. However, he may have some alcohol abuse, and there is like an kind of anemia when there is a chronic alcohol abuse, and when there is a chronic kidney disease, that there could be also anemia. So as we don't know if maybe he hasn't been treating for any kind of disease, so I would like to see his kidneys. I always relate, like, if there is small kidneys, I can think about a chronic kidney disease. However, his platelets are in upper limits, but I don't know what else to do with that.
Okay. Dr. Tulwani, does this help you at all?
It does, and I would like to see a differential too, but some of my, concerns are when you have somebody who has hypertension who comes in like this, is thinking of some sort of hemolytic type of process like HUS, especially with that diarrhea history, or atypical HUS, or even things like, hypertensive urgency causing a hemolysis pattern. So it does help me in making that less likely.
And for someone who drinks a lot of alcohol, that's a pretty high platelet count.
I agree.
That's just a sign of inflammation.
Yeah. So the rest of that doesn't help me as much. But I'd like to know, are there any schistocytes or anything else in this differential that may be revealing?
Right. So if he'd had a hemoglobin of 7 or 8, then we'd be going down that hemolytic pathway.
You got it. So this does help.
Before we roll out the UA, what about the HIV?
It's negative.
Okay, so it's time for the UA.
All
This
right.
is Dr. Tulwani's favorite test. And I hope everybody heard that when she goes to see a patient, she spins down the urine herself. Why do you do that? Because that's, I know it's the right thing to do, but my guess is everybody in the chat doesn't know why you do it yourself.
Okay. Well, first of all, the urine specimen sent down to lab, often it is, automated and not looked at carefully. And so it's not an accurate assessment of whether you have casts, et cetera. Plus urine has to be fresh, okay, to be seen. After 20, 30 minutes, the urine that's sitting out loses its, the structure of its cast or any elements that you see. So it's not that reliable. And so for me, by me getting it myself, spinning it down, I can ensure that it's a fresh urine sample. I can make sure it's obtained correctly. If it's in a Foley catheter, that it's new. And then I can go directly and look at it and trust my judgment rather than seeing what's on a automated computer. I don't have any other reason besides that. Plus I like looking at urine.
And sometimes you get an answer. So
and we do early get it. Like today, we looked at 3 urines and immediately we got an answer that made me have a decision about my next further step. Absolutely. Sometimes you don't get an answer.
Yeah. Okay.
All right. So drum roll. So UA specific gravity, 1.009, 2+ protein, 3+ blood, greater than 25 RBCs. That's where we're at.
Mm-hmm.
Okay. Does that help you, Dhruv?
Protein helps. The greater than 25 RBCs sort of helps. Spec grav is, I guess he slightly hyposthenuric-ish. My main concern is how much protein is he pouring out of his urine? Is that 2+ like nephrotic range, or is it like just enough that it can comfortably be in like a nephritic type of picture?
So John, somebody asked in the chat whether or not there were any casts seen.
So there were a couple red cell casts, but really not a lot.
Now I'm starting to think more of a nephritic picture.
Mm-hmm.
Okay, so Harry, now, if you were as experienced as Dr. Tulwani, you'd go get your own urine and look at it, and she would. If you're rounding with her, this would be a very exciting thing because you'd all go look at the urine, and it has to be warm urine, no cold urine.
Yeah, cold urine's gross.
Yeah. So
Ooh.
the thing here is to develop a differential diagnosis. And what are the most important things that could be going on with this patient with this urinalysis? So I want to discuss the specific gravity and then see if Ashita agrees with me. By the time you get to creatinine of 7.7, almost everybody is going to have a specific gravity of about 1010 because you lose your ability to either dilute or concentrate the urine. And anywhere between 1.008 and 1.010 is essentially isothenuric.
Correct.
Okay, so when you see this, that just tells you that this is not volume contraction, because volume contraction would be a very high specific gravity. And this is exactly what you'd expect if it's actually kidney injury. We now then have 2+ protein and 3+ blood and RBCs and maybe some RBC casts. So what I'd like everybody to do, and it'd be great for the chat to do this, is try to come up with what diseases he might have and how are you going to go about trying to figure it out. So everybody take about a minute, and then we'll let Kiara and Dhruv suggest some things for the differential, and then Dr. Tulwani will tell us if she was consulting on this patient, what she'd be thinking and what test she's going to order and why she's going to order those tests.
By the way, when I just came off the consult service last month, we saw the most beautiful red blood cell casts. It was just glorious.
I only saw red blood cell casts once in my career. And I used to look for them all the time because back in the old days when I was an intern, we had to spin our own urines, whether we went to nephrology or not. That's when they let us have microscopes on the floor. And then the pathologists were jealous or something and took them away from us. But the nephrologists hide them.
So for anybody who's interested, we do have our own microscope on 8 North at the, at the end of the hallway. Anyone's allowed to use it as long as you keep the room clean. Otherwise they take it away from us. And I'm always happy to show you how to spin urine. Residents know that they can find us hiding in the dialysis unit. And a lot of times they'll come and get me, or they take pictures, and I'll have to show you these beautiful red blood cell casts. I'll send them to you, and they send pictures of the urine to me, and that's really exciting too.
She can easily be found eating a donut somewhere in the IDU.
Exactly.
Yeah. If you could send that to Sean or me, we can put it on Twitter, a picture of red cell casts.
Okay, I will do that. My intern last month got it and sent it to me.
Okay, Kiara, go ahead and suggest some diagnoses that this man might have with this urinalysis.
Okay, so when I see this, I wonder what happened first, maybe the hypertension or the kidney injury. So this is kind of more than a nephritic cause than a nephrotic cause, maybe, and maybe this is the cause of the hypertension. So with that, maybe I will be thinking some glomerulonephritis, and there are many causes for glomerulonephritis, or maybe some post-infectious glomerulonephritis. So yeah, I will go with that. And when there is also affect. There's also protein, so maybe this will be a mixed component. That's are my ideas.
Dhruv?
So Kiara sort of started the idea where you have where you sort of have a range of nephrotic versus nephritic syndromes, and you can sort of have a spectrum where some things can sort of fit into both buckets. So things like membranoproliferative glomerulonephritis, I think can sort of have a both nephrotic picture. In terms of sort of the more purely nephritic causes, IgA nephropathy, post-strep glomerulonephritis can be one. I'm trying to. Lupus is another big one. I'd be more suspicious of lupus if it was a woman, if this patient was a woman. I'm trying to think of all of the.
Well, you've done well. So first question for Ashita is: does a urine protein, albumin, or protein ratio help us narrow down the differential? Because I don't know how to interpret the 2+ protein.
Yeah. So in this would be considered a nephritic pattern. And the various causes of nephritic pattern that already been said, plus currently others, can cause nephrotic range proteinuria with nephritis. And even though things like mentioned like IgA typically cause more hematuria, you can see nephrotic syndrome with that too. So just quantifying the urine proteinuria to see how much protein doesn't always help you. Unfortunately, nothing's black and white. But if you have significant nephrotic range proteinuria with red blood cell casts, then of course, some of the more commoner things that are more associated with it would be things like post-infectious or infection-related, what we call it, MPGN associated, or lupus. But all of them, truthfully, can still be associated with a nephrotic range proteinuria. The other thing to consider is that the proteinuria is not necessarily reliable because you have also lots of blood. which does contribute some to the proteinuria. And so realizing that that plays an issue too.
Mhm.
Does it change your differential? Well, let's say this is a low urine protein creatinine ratio.
No,
That doesn't really change your
no, it
differential.
does not, unfortunately.
Mhm.
Okay. So Sean has put some things up. He has post-infectious GN, IgA, lupus, myeloproliferative GN, ANCA. Is there anything else?
Okay, so post-infectious are now called infection-related GM. That's the new term.
Okay.
So let's see, where's your things? Oh, there you are, sorry. Let me see. Okay, so you've got MPGN, ANCA, post-infectious, IgA, lupus, infective endocarditis would be part of infection-related.
Mhm.
So yes, you got the majority, absolutely.
Okay.
And like a cryo picture.
Mhm, which would be part of MPGN.
Okay.
Okay. So it seems to me like when I call renal on a patient like this, they order about 20 things.
Yeah.
What 20 things are we going to order?
Well, first of all, for me, some basic things, because some of those 20 things can take, days to come back. One thing that also you can think about is it complement mediated or not complement mediated? And so one thing that comes back fairly quickly is just complement, C3, C4, CH50, which helps you think about one category versus another.
Mhm.
Okay.
So that's what I would start off with. But of course, the gamut of things looking at these different causes. I mean, essentially, if you're thinking about lupus, of course, ANA, double-stranded DNA, complements would help in that regards too. If you're thinking about MPGN, which is associated with hepatitis C or cryoglobulinemia, so hepatitis C levels would be also important. If you're thinking about infection-related GN, that's where complements would be helpful too. So that's the kind of serology I would start off with, just basic. And oh, sorry, ANCAs. I saw ANCAs there, sorry. So with ANCA, you would also think about an RPGN. So with ANCAs, there's one RPGN that's not listed here, which is what? Which causes a, pulmonary renal syndrome. Anybody?
Oh, it's GPA, I think. Or wait, is it GPA or is it
GPA.
Because it's ANCA related. Yeah, it would be GPA.
Okay, so I hear it now. Anti-GBM would be the other thing in this differential.
Yeah.
So was the chest X-ray okay, John?
It was within normal limits.
So does that help you at all, Ashita?
It does not, because when you look at many of these causes, can be very much renal limited. So with, the ANCA, the anti-GBM, the lupus, you do not necessarily see pulmonary involvement.
So are you ready for the big reveal? So John, give them the complements first.
Yes, sir. So we have C3 and C4 are both within normal limits. PPO, PR3, and ANA are also negative.
Which was my suspicion.
Okay, so your suspicion. So explain your reasoning for us, Ashita, because I think this is really great.
I could be completely off, but my thought process, and I could be completely wrong. If you're talking about this rash, which I don't know if it's really a rash or what's been described, and the diarrhea, basically something that comes to mind for me is IgA nephropathy. And so with IgA nephropathy, it's associated with all those things, associated with celiac sprue. You can see various different dermatological issues with it systemically, and that would not cause low complements and can have a progressive GN. In fact, I've seen several IgA nephropathies recently in this age group that presented that way. And so
is there anything else that will give us a progressive GN and have normal complements?
So of course, anti-GBM and ANCA would do so, and some of the lupus can do so too.
Okay, so we have ANCA's negative.
And you can think about things, there are other, organisms, et cetera, that can cause like a vasculitis syndrome for sure. That'd be associated with the progressive GN.
Okay. So
I think the chat's
wrangled-
blowing up on like a filarial nephropathy that might be there, considering that he's, in water constantly and might have some weird worm exposure.
So I must confess, that's not, something I'm used to seeing. I suppose, you can have even glomerulonephritis with schistomyositis, but so that would be, with this water intake, that would be something I guess you could consider too.
So John, tell them the rest of the labs.
All righty, so we are antiphospholipid negative, lupus negative, cardiolipin negative, beta-2 glycoprotein negative, GBM positive.
Okay, there you
Huh.
go.
So he has anti-GBM disease.
So Ashita, it would be great if you could sort of summarize the thought process that one would go through. So if you got called to see this patient as a consult, you'd get to the right answer.
Yeah,
Teach us how you think through it.
Yeah, so essentially anyone who's got red blood cell casts or nephritic/nephrotic picture, you've got the differential. And so the serology is there for you to order, okay? And so definitely all those things we talked about would be ordered. Complements come back faster than anything else. So if your complements are negative, then of course it leads you to the RPGN category or IgA nephropathy category that we talked about. And then your differential comes with that. Typically then what we would do, honestly, because some of the serology, even anti-GBM, would take a long time, is this is someone who I would biopsy. Something that's always important to consider in these patients though, is what we didn't talk about, is renal ultrasound and size of kidneys too. Because size of kidneys can sometimes tell you the chronicity of the problem, not always. And so this patient, I don't know how long it takes an anti-GBM. I think it takes a couple of days. Probably I would have biopsied him and got that answer.
John, what actually happened?
That's actually what we did. So we had a renal ultrasound that just had non-specific sort of enhancement of the parenchyma, but kidneys generally were grossly within normal limits as far as their size. We did biopsy him and it showed crescentic glomerulonephropathy on the preliminary findings.
So the other thing is, when you think about anti-GBM, which definitely can be renal limited, we've seen it, there's also associated between that and hydrocarbons. So I'm curious to see if there's any exposure to that, especially just curious.
And how would you treat this patient?
So steroids would probably be the first answer, and then probably cyclophosphamide or some other immunosuppressants.
Kiara, you're shaking your head.
So every time I think about this kind of some autoimmune disease, top of my head, steroids, and yeah.
So Ashita,
Immunosuppressive.
how would you actually treat this patient?
So I agree. This patient needs, immunosuppressive therapy, traditionally steroids, and whether it is basically cyclophosphamide or something else, you can. But the major process is going to be plasmapheresis. And actually, when you have a creatinine already greater than 5, like this gentleman had, I don't know if I'm supposed to say this or not. I don't know how much I'm supposed to say, but that has a less prognosis for kidney recovery, by the way.
Yeesh. Yeah.
John, how'd the patient actually do?
Not great. So basically, he stayed with us for a couple of days. His kidney function stayed where it was. He got dialysis several times. And then he decided to leave AMA. And his GFR was 5 at that time.
Why?
Yeah.
Why?
So I'm sure he'll reappear.
He taught us a lot.
He did. That was his parting gift to all of us, was knowledge.
So he's probably somewhere on dialysis now permanently. But some of the other things I want to mention, with this case that I would have also gotten, and again, I don't know how much I'm supposed to say or not. So
you can say anything you want to, because
the game's over.
The game's over now. Okay. So I would have probably got also a urine drug screen too on this gentleman. Okay. We are seeing cases of, his ANCAs were negative, but you can see, you have to think of like ANCA vasculitis when someone's taking heroin or cocaine that's laced with that.
All right.
Yeah, I can never pronounce it. Exactly. Levetzomal. Is that right?
Levamisole.
Whatever, close enough. And
The
so, and we've
antiparasitic that's used to cut cocaine.
exactly, which I think it kind of increases the intensity of the response. Is that right? I don't know.
I
Yeah,
don't know. Are you asking for a friend?
I don't know, but that's what I heard. So that's something else you have to think about in this case, because we have seen, one or two of those cases too. But clearly, anyone who has this pattern, you can wait for the serology. The serology will take time, but honestly, biopsy is the best way. When I finished my fellowship here and did renal, essentially we would perform our own biopsies, and we'd actually do them even on a Saturday. On the vent, they would, unfortunately, things have gotten more regulated now, and you can't do that, and pathology is hard to bring. But I've made so many diagnoses by biopsying someone on a Saturday, specifically ANCA-related vasculitis. Something like Trigg-Strauss was one patient I saw. So renal biopsy would probably be the biggest key in these patients for several reasons. Not only to make the diagnosis without serology, but prognosis purposes. If you already have a creatinine of 7.7, the issue is, am I going to slam him with high immunosuppressive therapy if he's got, 70% chronic interstitial nephritis? If that's the case and the kidneys are gone, no, I'm not going to subject him to therapy that might cause more harm. And so the prognostic part of a renal biopsy is just as important as the etiology and findings.
Well, if we could have a virtual round of applause for Dr. Tulwani.
I didn't do anything. You guys did it all. This was a great case. But never forget IgA nephropathy too, because that's like the biggest massacre now. I've seen all variations, crescentic, et cetera. It will surprise you.
Question though, when should we be more bold about doing renal biopsies when we think that they are going to give us diagnostic?
Absolutely, especially if you have a young patient. Absolutely.
Is the trigger that it's nephritic? Are you as quick to do it if it's pure nephrotic syndrome?
So the trigger would be nephritic, and the fact that would be the differential with something that, if you don't treat in time, would progress to end-stage renal disease. So with many of the nephrotic syndromes, you can watch and wait, depending on what the type is. FSGS, membranous, minimal change, of course, that's a diagnosis that would need a renal biopsy. But many of the things, depending on the demographics and the age group, you can watch before you essentially stick a needle in.
So it's
or things where you have another etiology that if you treat that, the kidney disease is going to be gone.
So it was the red cells and the red cell casts. Well, even if he didn't have red cell casts, just 25 red cells in a man with this kidney picture would be enough to get you to do a biopsy.
Absolutely. And I would look to see, are the red cells dysmorphic or monomorphic? Dysmorphic is more a characteristic of coming through the glomeruli. And so, but absolutely, even if I didn't see that, with this picture, a young gentleman with, no previous history, absolutely I would biopsy him.
Ashita, thank you so much for joining us tonight. You, as expected, you were brilliant.
I wasn't. It was a good case. It was fun.
No, well, that's why we picked this case, because we knew you'd have a good time with it.
Absolutely.
They presented it to me at Morning Report. John, I don't know, was about 3 months ago.
Yes, sir. Something about that.
And I immediately said, we need to present this to Tulwani.
That was actually the first thing that he said.
Yeah, no, really, because you're so good at this, and hopefully everybody learned a lot. All the people in the chat, and Kiara, I hope that you learned a lot from this. Dhruv, I hope you learned a lot from this. I learned quite a few things from this, so it was great. Thanks, everybody. Quick vote. Next Tuesday is election night. It's probably not the best possible night to do unremarkable labs. Should we skip a week, or should we reschedule for Wednesday, let's say?
Yeah, skip a week.